Good afternoon, everybody. I hope you can hear me. And I would like to thank you very much for joining us in this webinar and for deciding to participate to this, let's say, evaluation of what we learned, or what we confirmed, or what we changed during the recent European Society of Cardiology meeting in Munich at the end of August 2018. The topic we will address this afternoon is chronic ischemic disease. And in this area, the big bang has been the publication of the ORBITA trial. There is one thing I would like to underline to start with, is that the ORBITA trial, as you can see from this diagram, after 40 years of angioplasty in practice, has been the first prospective randomized trial with placebo control. So before discussing the results of the study, let me emphasize the importance of the design, not only in this area, but in every area, the design with a placebo control and a randomization. The other peculiarity of this trial that may, at least in part, explain the results is that following the inclusion, at least the consideration for the study, patient had a medical optimization phase where the medical therapy was optimized to see what was possible to achieve with this strategy. And this preceded, of course, the randomization to a real angioplasty procedure or a fake angioplasty procedure. This is the first study ever in the history of interventional cardiology where the placebo arm is not just a sugar pill, but is a fake angioplasty procedure. So the patient was not aware if he had received a real revascularization procedure or just a coronary angiography. And as you know, the result of the study have been impressive. This is the report of the titration of the medical treatment in the inclusion phase. And as you see, patient moved from 1 to an average of 3 drugs to control the angina symptoms. Of course, this was done both in the real PCI and in the fake PCI arm. And the conclusion of the study is that following this approach, there was no difference, no significant difference among the two groups of patients in exercise time, in tolerance to physical exercise. That's why the authors observed and reported that medical therapy increased the prevalence of asymptomatic patients. You may see here how the column of the Class 0 Canadian Society classification that was absent in the inclusion time by protocol start growing, and just at the follow-up you see that 1/3 of the patients were completely asymptomatic, and also the Class 3 was dramatically reduced. So there was a similar improvement in symptoms and in quality of life in both the real angioplasty group and the fake angioplasty group. The conclusion of the authors was that even in patients with severe coronary stenosis, exercise capacity and symptoms are not improved significantly compared with a placebo intervention. You can imagine easily the reaction to this statement in the community was a fierce reaction. And in my opinion, this reaction was not really justified, because this conclusion actually were already present in the literature. You see, 4 years ago, in the JAMA, Stergiopoulos and Bowden and other cardiologists published this meta-analysis of contemporary randomized clinical trials. And the conclusion, so surprising, of the orbital trial actually had been totally anticipated by this meta-analysis, where you can see that there was no difference among medical treatment and angioplasty in mortality, in myocardial infarction, in revascularization, and in angina. So the problem was not the orbita. The problem is that this sort of information do not receive a, say, wide acceptance in our community. But it would be somehow simplistic to limit the comparison between medical therapy and revascularization to the efficacy, because we have also to consider safety. Now, from a safety point of view, there is a major difference between medical therapy and interventional procedure. These are the rates of adverse event reported for elective interventional procedure in the United States and in Europe. This percentage may look relatively low, but if you consider that every year more than 500,000 patients between the United States and Europe receive a PCR procedure, then you may estimate more than 3,000 deaths, 78,000 myocardial infarction, 65,000 kidney damage, 1,000 strokes, and a very high number of vascular complications. This cost is not compensated by any advantage from the efficacy point of view. There is no additional benefit to compensate this risk or, let's say, harmful complication of interventional procedure. These data have been even, let's say, more recently confirmed by this report, where the prevalence of myocardial injury after an interventional procedure is around 22%, and the prevalence of kidney damage is, on the average, around 10%. So when we compare to treatment, we cannot limit the comparison only to the efficacy side, but we also have to consider the safety side. And if medical treatment and angioplasty have similar results from a, let's say, a symptomatic point of view, in terms of safety, the difference is striking. And one other thing that deserves some attention is that by no means PCI should be perceived as a conclusive procedure. This is an illusion of many cardiologists and many patients too, that following the PCI you will live forever and happy life. Unfortunately, this is not so. In this recent report published on the Cardiovascular Intervention Journal of the JACC, you see that 10% of the patients, to me an extremely high percentage, following a quote-unquote successful PCI, need hospital readmission within 1 month. And this study also confirmed let's say, the harmful nature of this approach, because there is a 2.4% of mortality, in hospital mortality, for the index procedure. The mortality rises to 2.8% in subsequent readmission, and it's even greater, 3.1%, if the readmission is not for cardiac reasons. Even more common is the need for readmission if the patient discharge occurs against medical advice. So we are dealing with a very complex situation that probably we have a little bit underestimated in its complexity and in its, let's say, risky nature. But all these comments should not be interpreted as a technical remark to the procedure. The persistence of angina following successful procedure, the recurrence of angina, and even the adverse, more severe adverse event are not technical failures. are not a problem of stent deployment or stent choice, are a cultural failure, because we fail to realize that the mechanism precipitating myocardial ischemia are much more complex than just coronary stenosis. The link between obstructive coronary atherosclerosis and ischemic heart disease that we assume to be a very strict one actually is much more elusive than we were taught and than we like to believe. The mechanism that may precipitate myocardial ischemia include a critical coronary stenosis, but also include many other factors like inflammation, platelet and coagulation disorders, micro and macrovascular vasospasm, microvascular dysfunction, endothelial dysfunction. And this is not just, let's say, an expert opinion or a personal opinion. This multifactorial nature of ischemic syndromes has been fully acknowledged by the European Society of Cardiology in the most recent guidelines on this topic, where, as you can see here, there is a long list of mechanisms responsible for myocardial ischemia that include fixed or dynamic stenosis, microvascular dysfunction, focal or diffuse epicardial coronary spasm. And possibly the most important recommendation of the European Society is the last line here, suggesting, actually warning, that this mechanism may overlap in the same patient and change over time. So we are dealing with an extremely dynamic condition that prolongs in time, possibly for the entire life of the patient, changing in nature, a changing modality of presentation, and changing the responsible mechanism. This observation is critical in the practice of cardiology today and should, if entirely, let's say, understood and applied, change dramatically our approach to these patients. So we no longer have to deal just with occlusive coronary atherosclerosis, and that was easy in a sense, but we have to deal with dynamic form of occlusion that we call coronary vasospasm, and then we have to deal with a new world that is called microcirculation, where there will be all sorts of functional and again on structural abnormalities that are not yet fully understood. And then we have other extravascular factors also involved, like LVH, calcium overload, amyloidosis. So you see how much more complicated is the world of ischemic heart disease than just presence or absence of a stenosis. And also consider that of all the mechanisms listed in this slide, only this one is visible on coronary angiography. All the other mechanisms are not visible. And that's why the guidelines suggest that coronary angiography, or I rather say coronary anatomy, is not useful in ruling in or ruling out a diagnosis of myocardial ischemia. Now let's go to the treatment of chronic ischemic heart disease. Let me point to this first line here. As you see, there is only one class 1 indication to revascularization. Remember this. In chronic ischemic heart disease, there is only one category of patient where there is a class 1 indication to revascularization. And these are the patients that have unacceptable angina, despite guideline-dictated medical therapy, and have at least one stenosis that can be treated with a procedure. The immediate implication of this statement is that there is no right of choice between angioplasty and medical therapy. This is over now, because revascularization can be considered only in patients that receive guideline-dictated medical therapy. So medical therapy is the first line of treatment always. There is no patient that can skip this step. and PCI to be considered in patients with angina refractory and suitable anatomy. This is again a major change as compared to the previous guidelines, where there was some uncertainty. What is better, medical therapy or PCI? There is no longer any question like that. There is medical therapy, and in case of failure and favorable anatomic condition, you may consider revascularization. So medical therapy is the mainstay of treatment of chronic ischemic disease, but which medical therapy? And let's go back again to the guidelines. Here, I mean, we have a major problem in my understanding, because the guidelines propose a sort of ranking order in the choice of drugs, identifying first-line agent and second-line agents, you see? Now, and they include in the second-line agent trimetazidine. This insert that you see here is taken from the American guidelines, where they report trimetazidine is an anti-ischemic metabolic modulator with similar anti-anginal efficacy to a beta blocker. And this has been proven in a head-to-head comparison. So trimetazidine is at least as effective as a beta blockade in controlling angina. But there is a major problem with this ranking order in anti-anginal agent. And the major problem is that this is not evidence-based medicine. We went back to the last 50 years of medical treatment in angina. We looked at all the drugs that had been used along these decades, and we concluded that there has never been a study showing the, let's say, the superiority of any agent compared to the others. As I told you before, even in the comparison of trimetazidine and beta blockers, they were even at the end, at least in terms of efficacy, of course. So there is no scientific evidence in stating that this agent is better than this other agent. There is no evidence that one drug is superior to another. And so we think that let's say, the hierarchical recommendation should be reconsidered. But there are other limitations in that recommendation of the European Society. The major limitation is that in that ranking order, there is no effort to match the drug with the mechanism of ischemia. I'll make you an example so you will immediately understand what I mean. How can you put in the same level calcium channel blockers and beta blockers? You cannot choose indifferently one or the other. If the angina is a vasospastic angina, you are bound to prescribe a calcium channel blocker. If the angina is an exercise-associated angina, then you are bound to prescribe a beta blocker. You cannot just choose, because both of them are in the first line, I can choose either one or the other. You must consider which is the mechanism of ischemia. And of course, that ranking order is not based on scientific evidence, but there is one other point that's not considered in those recommendations. And the other point is, which patient are we dealing with? Is this a patient with hypertension or hypotension, with tachycardia or bradycardia, with diabetes or non-diabetes, etc., etc.? So we cannot just say a theoretical list of drugs. We must translate this into a clinical approach, because to summarize this concept, not all chest pains are angina pectoris, and today more and more we read papers where under the heading of chest pain, anything is bumped, maybe an orthopedic problem, a gastrointestinal problem, or a true ischemic problem. So not all chest pain are angina, and we want to treat angina, not chest pain. Not all angina are equal, because you may have a exercise-associated angina, a spontaneous angina, a resting angina, etc., etc. And not all angina patients are the same. One thing is treating patient in a 90-year-old patient or in a 50-year-old man, etc., etc. So that's why we propose a much more personalized approach to the treatment of angina. And we were lucky enough to publish this document on the Nature Review in Cardiology quite recently. The message that we want to deliver with this review is that the diagnosis of angina is just the first step of a journey. So you already established that the chest pain that the patient described to you is angina pectoris. Fine. This is not the end of the diagnostic journey. It's only the beginning of the diagnostic journey. The second step will be to establish, or at least to try to establish, if this is a stable exercise-associated angina, if this is a microvascular angina, if this is a vasospastic angina. These are the three main categories that you have to identify in each patient with typical, angina typical. But the second step is which is the cardiac condition of that patient. Does he have heart failure, or maybe simply left ventricular dysfunction? Is he hypotensive or hypertensive? Is he bradycardic or tachycardic? Does he have arrhythmias like atrial fibrillation? So all these elements must be considered in the design of the most effective strategic treatment. And eventually, the third step before identify the drug or the drugs combination is to consider what is outside the heart of that patient. You may have diabetes, chronic kidney disease, chronic obstructive pulmonary disease, peripheral artery disease, or you may have a problem of IV conduction, etc. So all these things must be taken into consideration if really we want to identify the most appropriate treatment and make the best drug selection. And these are the drugs that we may choose to treat this patient. There are drugs of proven efficacy, the top part of this slide, and drugs of possible efficacy that still are in a development phase. Let's focus on this part, where you see we have drugs that we can call hemodynamic agents because they focus on either heart rate reduction or blood pressure reduction. So these are on the side of the cardiac external work, trying to mitigate the metabolic demands of the heart. Or we have metabolic modulators like trimetazidine and ranolazine. So two different strategies. But we also, my recommendation is to be humble and honest with the patient. Humble and honest. In my understanding, as of today, October 2018, we have no therapeutic resource that can promise the patient to live longer. We have no resource by which we can promise the patient that he will never have a myocardial infarction or heart failure. The only reasonable promise we can give to our patients is that we may improve the quality of their life. So forget prognosis, forget survival, forget myocardial infarction. We are unable to impact on prognosis of the patient. The only thing we today can do is improve the quality of life. This is important to consider because if this is the main target of the treatment, what we choose should at least not worsen the quality of life of the patient, not have side effects that could make him living worse life. And so not only the drug that we prescribe must be of proven anti-anginal efficacy, but these drugs should have as little contraindication as possible and should have no relevant side effect that may jeopardize the quality of life of the patient, what we want to improve. So, and this treatment, once we have established, we have to maintain basically lifelong. Anti-angina treatment is a lifelong commitment. Don't be too surprised from this statement. Ischemic heart disease is no different from heart failure. It's no different from hypertension. It's no different from diabetes. Nobody really heals from heart failure. Nobody really heals from diabetes. And that's similar in ischemic heart disease. Once you have formulated this diagnosis, get ready to assist that patient for his entire life. ready to adjust your treatments according to the changes in the, let's say, pathogenetic pattern of the myocardial ischemia. Because if you de-escalate anti-anginal medication, even following a successful PCI, you expose the patient to increase the risk of recurrent angina and certainly to a worse health status. So be ready to handle this situation as long as the patient refers to you. But we have a wonderful tool. We have a really wonderful tool that's called tremetazine. That means a strategy based on modulating cardiac energy metabolism. This has been shown to reduce the risk of recurrent angina following a successful quote-unquote procedure, and also to significantly reduce silent myocardial ischemia. Silent myocardial ischemia. Most patients following, after they have been told that their problem had been fixed with a stent deployment, they tend to deny myocardial ischemia. But if you test them with any stressor that you want, you will find that the prevalence of post-PCI ischemia is almost close to 50%. 50%. And this prevalence is significantly reduced by this metabolic modulation. And this is probably the sort of underestimation of the relevance of this condition is responsible for this depressing figure. What this slide tells you is that only 2/3 of the angina are correctly diagnosed. Most of these patients are treated only with one agent, despite the persistence of angina. And as you see here, 30% remain symptomatic. And despite this, there is no escalation in treatment. It's like if the doctors or cardiologists do not react to the persistent discomfort of these patients, or even they might deny the presence or the persistence of the symptoms. There is a sort of attitude to no longer consider the role and the implication in terms of quality of life of angina after a revascularization procedure, like it will disappear. And the conclusion is that to a large fraction of patients with symptoms after a procedure do not receive optimal medical treatment. And this inertia, honestly, is difficult to accept. So, dear colleagues, I want just to again emphasize that we have a very helpful tool that is this modulator of cardiac energy metabolism, and this approach is effective independently from the background treatment already taken by the patient. In this cartoon, you see that you have a similar beneficial response in patients receiving wholly beta blockers, in patients receiving beta blockers plus a calcium channel blockers, in patients receiving a beta blockers plus a long-acting nitrate, and even in patients receiving the 3 drugs, beta blockers, calcium channel blockers, and long-acting nitrates. The addition of tremetazine is consistently associated with a dramatic reduction of the number of angina attacks per day or per week. And also irrelevant is the, let's say, is the natural history of the disease, in the sense that this approach, again, is associated with a dramatic reduction of the number of events, irrespective if the symptoms were present for less than 1 year, for less than 4 years, for less than 9 years, and even if they were present for more than 9 years. So this is really a very, very effective tool that we have. And so, my dear colleagues, we get to the final slide of this presentation, where I try to summarize which, in my, I say, humble perception, are the main concepts that should today guide in managing a patient with chronic ischemic heart disease. And these main concepts are, number one, chronic ischemic heart disease is a multifactorial condition. So it's not just a problem of stenosis yes or stenosis no. It's not just a problem of stenosis more than 70 or less than 70%. It's a problem that stenosis may be present and angina not, or angina may be present in the absence of a stenosis. So we have now to deal with a completely different story, ischemic heart disease, independently from presence and severity of a chronic stenosis. So in diagnosing and in treating chronic ischemic heart disease, we must consider that the precipitating mechanism may be not visible or not deductible from coronary anatomy. They need functional testing, and they may be present in the same patient at different times in a different pattern. The third concept is that chronic ischemic heart disease is a lifelong condition. Once you have been labeled as an ischemic patient, you stay that for the rest of your life. Like heart failure, diabetes, hypertension, you will always need treatment. And the treatment cannot but be medical treatment. There is no option to this, there is no alternative that can be considered. Medical treatment should be started immediately. It should be always the first approach to this patient and should be maintained lifelong. And to this approach, the most attractive alternative is tremetazidine. Not only for its efficacy, that is, has been compared with other agents and has been shown to be at least as effective, but because of its tolerability profile, that by no means is the best available. Thank you very much for your attention. Now I'm ready to answer, if possible, to your questions.